Coffee. Good morning, everybody. Dr. Richard Ulm here with Dr. Bradley Muse. Again, we wanted to talk about just cases and stuff and drink good coffee. This one is, I think it's from Honduras, but I get it from Stoff's down in Grandview, which is great. Anyways, we're going to talk about the TMJ today. And we've got some kind of cool things, right?
Right, so we're going to talk anatomy, and then we're going to finish up how we treat it. So make sure you guys watch till the very end, because we're going to give some really good tips on how to manage some of these things on your own.
Right, we've got a nice little not teaser, it's actually something that we give to 100% of the patients that come in the door, at least I do.
Yep.
That come in with TMD. Now this is really funny, everybody comes in and they say, Doc, I have TMJ. TMJ stands for temporomandibular joint. So saying that you have TMJ would be the equivalent of coming in and saying, Doc, I have elbow, or I have shoulder, which is always funny. Sometimes I correct them, sometimes I don't. Doesn't really matter. TMD stands for, is that better? TMD stands for temporomandibular dysfunction. So what we're going to talk about today is just that, the temporomandibular dysfunction piece.
And I promise this is not another McKinsey video.
Nope.
We could talk, well, okay. There may be a little bit of McKinsey within this.
We might
we'll
reference it, but it's not just a McKinsey video.
We are going to talk, I mean, we're two certified McKinsey doctors.
Right.
We have to
just
noted a little bit. But we're going to give you guys some tips and tricks and show you guys how we treat this a little bit.
I think a good place to start is really, why do we know about the TMJ? Why do we treat the TMJ? And the simple answer is, a huge influence to both of us, sort of like the father of manual medicine for a lot of chiropractors. He's actually a medical doctor from the Czech Republic. His name is Karl Levitt. And, he basically practiced all the way up until really 2011, I think, is when he passed away. But he was 96 years old doing rounds in Prague in the hospital, this very, very famous hospital that's got legends that came out of there. Such as Vladimir Janda, that some of you might know. Even in the strength training community, you guys might know him. And then also Pavel Kolaj, which is a guy that's been a big influence to us as well. Karl Levitt said that 100% of cervical spine dysfunction has TMD involvement, and 50% of it is the primary problem. So as we've said many, many times, we try to really fix the problem here. And when we go through and we're doing our evaluation, if somebody just comes with just good old neck pain, we have to really look at the jaw because, as I believe, and as Karl Levitt states, a vast majority of those are going to have TMD involvement. So we got to do it. That's why we know that. So both of us have taken classes on treating this. One of them's from another influence of ours, Dr. Brett Winchester, who's in Troy, Missouri. He's actually got a good group called Gestalt, which we'll certainly tag in here because they're good guys. But yeah, so that's why we actually know this, because I think a lot of patients and a lot of dentists find it a little bit odd, like why would a chiropractor do that? And I think it's because they believe that we're thrusting on the jaw, which is not happening. We'll talk about that when we get into how we treat.
Yeah.
So
first, to cover a little bit of the anatomy, there's two big muscles that I'm primarily going to bring up, and that's the masseter, which if you clench your jaw, you're going to feel kind of pop out. And then the temporalis, which sits up in the temple. So same thing, if you clench your jaw, you feel it kind of pop out at you. Both of those muscles are responsible for closing the jaw. So especially in today's world, sitting at a desk, constantly go. A lot of us are clenchers, or we do what's called bruxing, which is more of a rhythmical clenching.
Rhythmical super clench.
Yep.
If someone's a bruxer, you'll probably hear this at night usually, and it sounds like amazing teeth grinding. People who are bruxers are the ones that break through mouthpieces at night, mouth guards, orthotics, whatever you want to call them. Right. They're the ones that, like, if you hear it, it is in some cases a shockingly even gross sound, because of how massive it is.
Right. And in the past with TMD, they used to talk a lot about occlusion. So how do the teeth come together and line up? Nowadays, that seems to be less of a concern for us. Now we may work alongside a dentist and say, Maybe somebody is a candidate for some kind of orthotic for the mouth, but for the most part, it's the clenching and the bruxing that's the primary thing that we look at. Now, those are the muscles that primarily the big ones that are going to close the jaw. But then we talk about some of these smaller muscles underneath called the digastric.
We'll just say smaller muscles than there's
Right.
probably 20 of them. There's a lot.
So when we treat this, we're primarily looking at two things. Can we decrease the amount of tension in the ones that close the jaw? And can we activate the ones that are responsible for opening the jaw?
That's actually
pretty simple.
Yeah, so one of the other guys I just referenced, Pavel Kolaj from DNS that we've been influenced by, he always is trying to get the patients to be able to what's called functionally centrate their joints, and it's a deeper concept, but the sort of a quick and dirty version of it is when you have a functionally centrated joint, that joint has balanced muscle activity around it, and that's a major goal of any treatment plan for somebody that walks in, whether it's TMD, plantar fasciitis, whatever. We're trying to establish muscular balance or functional centration. Because when you have that, things work better. So in the jaw, we're trying to reduce the clenching activity of the temporalis and the masseter, and even another muscle on the inside called the medial pterygoid. And then we're trying to activate a lot of these other smaller muscles down here so that we can have a functionally centrated jaw.
Mm-hmm. And in line with the centration thing, like this is how we tie in the neck. Most of us today present with a forward head posture, and that may be because we work at a desk or some kind of flexion dominant activity. So if my head is listed a little bit forward on the neck, then we change the muscle tension relationships that can then affect the jaw. So that's why looking at the neck is a huge factor here. One major thing we haven't talked about yet is the disc that sits within the TMJ. So this is a major component to treating TMD. So the disc, if you think about how the jaw comes up, it sits on top of it and separates the temporal bone and your jawbone. So in a normal functioning disc, it has an area that has no blood supply and very little nerve supply. So in a normal functioning jaw, no pain. What we typically see more often than not is that the disc migrates forward and there's a hypersensitive area to the back of that slides forward, and then we begin to compress it, and that's where you get the pain. So
yeah, you get a lot of pain when again, this is all made possible by a functionally decentrated jaw. Mm-hmm. So when you're opening and closing, that's where like it sort of clicks here and back. That's where you get that popping and clicking. Sometimes it's non-painful, but that popping and clicking is usually that disc, which you can think of the disc almost like a more thick version of your meniscus in your knee. It's made of similar material, mm-hmm. and so it will sort of pop in and out there, and that can cause, obviously, sound. It can cause jaw movement, and then it can, of course, cause pain. So a lot of people come in and they get a painful pop and click, or worse, they're not able to get full opening.
Right, and that's typically what we see is someone who's unable to open the jaw. So a good test for yourself, 3 knuckles width typically is how far we should be able to open the mouth up. So you can test yourself right now, see if you can get your teeth around the 3 knuckles. If so, then that tells us that we have a pretty adequate range of mouth opening. Go ahead. I lost it.
I got it. There. So that was maybe enough for the anatomy. We could talk about this for hours. We're going to jump into then how do we treat it. So we talked about why we do this, because they're always involved with cervical spine cases. So we need not only to be able to assess the TMJ to properly treat a jaw, to properly treat the cervical spine, but we need to be able to assess the cervical spine to treat the jaw. Now the question is, how do we treat it, right? We're not obviously thrust manipulating this thing.
Right.
I think some people might do that. That sounds like a terrible idea to me. But
yeah.
So how do we treat it?
So we have to talk about a little bit of McKenzie. I swore we'd try to stay away from it, but it is such a powerful tool. So just like the low back and the neck, there's a typical directional preference or direction we could move the jaw to see if we could reduce the symptoms. So that's
what a direction of preference is.
Right.
It could be any joint. It's typically applied to the spine. It's incredibly powerful. You're trying to find the direction that you can repetitively move a joint that produces positive results, which could be reduction of symptoms, improved overall movement and function, and all that good stuff.
And to go back to the disc, so it typically, more often than not, is going to be migrated forward, and that's going to limit the amount that we can open the mouth. So that's typically what presents. If it goes backwards and they have a hard time closing the mouth, that's a completely separate deal, and that's actually a little bit more of an emergency. But if it's slipped forward, our goal is to reduce that derangement of that disc and kind of get it to migrate back to its centrated position. So the typical directional preference for the TMJ is going to be protrusion of the jaw. So good thing that a lot of us are wearing masks right now. So like I recently gave a high school female student this exercise for this. I thank God that you're wearing a mask because people are going to judge you if you're sitting there pushing your jaw forward all day. So the way that we teach this is sitting up straight, and all I want you to do is try to jut your jaw forward as much as possible.
12 minutes.
Awesome.
We got to get going.
So that's going to be one home exercise. Another one that we talk about is the resting jaw position. So
These are home exercises.
Yes.
What do we do for treating?
Oh, so treating, there's going to be, similar to other things, we're going to use
You have 2 minutes to do
soft
this.
tissue techniques. So that could be ART with our hands. That could be needles that we may needle the masseter, the temporalis, the muscles we talked about that are being hyperactive.
So I'm putting them on a clock. You're going too fast, right? Just so we're gonna treat the jaw, right?
Yep.
So we want to reduce the muscles that are overactive. We want to activate some of the muscles that are inactive, which could be some of the muscles in the neck, like he talked about. There's certain drills that we can give for mouth opening and closing and all that good stuff. There's also, of course, treating the spine.
Yep.
So that's important. And then the McKenzie stuff and then the home exercises is really good.
And a big one is going to be resting jaw position.
This is the teaser. This is what we teased about.
This is a big
teaser
one, especially
alert.
for our clinchers who are constantly clinching. A good resting jaw position is going to be lips together, teeth apart, the tongue on the roof of your mouth as if you're about to say the word no, and then we're going to nasal breathe. So that's the best resting jaw position to give relaxation to those muscles we said are overactive.
Many of you, if you have TMD, which would be clinching, popping and clicking, or painful sort of jaw, it's a very broad term for just shit that goes wrong with your jaw, basically. If you just tricked yourself into trying to achieve this position as much as you can, so you can put stickers around if you want. I find it more effective if you just say every time that you hear your phone go off, whether it's a text or an email or anything, it surprises you and you can think, okay, is my jaw in the right position? And if you keep doing that, it might take you a couple weeks, but if you're very, very persistent with that, that alone will literally fix, I would say, more than half the TMDs that walk into the office.
Absolutely.
Any closing thoughts?
No, I mean, the big thing is, chiropractors treat that too, especially here in our office. It's something that we have studied a lot, so if you guys have any questions, make sure you guys reach out to us. We'd be more than happy to talk to you about any questions you may have, but other than that, hope you all have a good Wednesday, and we'll see you guys next week.
See ya.